Finance and Policy Committee will come to order, and the committee legislative assistant will note the roll there. Good morning, everyone, and thank you for being here at 8:15 on time. I'll talk to Representative Franson later. Just want to thank everyone who applied to be on this committee and requested this. There's a lot of good work that will be coming forward this year. I'm sure there's a lot to be done. There's a lot of changes in the human service area that I think are exciting and things to get excited about. And so with that, I just want to begin with introductions, and then we'll have a walkthrough, excuse me, of the committee jurisdiction with Nonpartisan staff here today. As a reminder, the little red switch in the front by your microphone keeps you from getting in trouble, so please use that judiciously as we go throughout the day. But we'll start with a little game of Guess Who, and we'll play with the board down at the end of the table and move this way.
Tom Brennan, Partisan Research.
Jeff Backer, State Representative, District 9A.
Steve Gander, House 1B.
Jimmy Gordon, 28A.
Steve Jacob, 20B.
Krista Knudsen, House District 5A.
Tom Murphy, House District 9B.
Don Gilman, District 17A.
Megan Rosbach, the Committee Administrator.
Joe Schumacher, District 21A, Southwest Minnesota.
Joseph Fruhoff, Committee Legislative Assistant.
All right, that was painless. So now let's see if we can make the rest of the day go that way. And we'll have welcome to the committee team. And if you could please introduce yourself for the record and then start with your presentation. And we'll take questions in between. They'll be lobbying off between their team down there to talk about the different areas. So when they're ready to transition, we'll take questions of those areas at that time. So if you have any questions, just please signal to us and we'll get that noted for that time. Begin.
All right, good morning, members. We're collectively the nonpartisan staff that staff Health and Human Services as opposed to Human Services. We're going to do a presentation for you today providing quite a bit of general information about the whole subject area. First with the introductions, I'm Doug Berg. I'm a fiscal analyst for the Human Services Committee, Health and Human Services Committee. I also handle children and families. My main issues that would pertain to this committee are long-term care, disability waivers, and direct care and treatment, and substance use disorders, and a lot of little things, or lesser things. They're not little.
Chair Schumacher, Joe Harney, House Fiscal. I also staff Chair Backer's Health Finance Committee, but for this committee, I'm responsible for behavioral health, housing and community support, and program integrity and central office operations.
Good morning, Mr. Chair. I'm Danielle Pinelli from the House Research Department. I staff this committee and also the Children and Families Committee. For this committee, I'll be covering long-term care issues and also housing and community support issues.
Mr. Chair and members, I'm Sarah Sunderman, also from House Research. I staff this committee and the Children and Families Committee. And for this committee, I cover behavioral health, direct care and treatment, vulnerable adult protections, and program integrity and operations.
And of course, it doesn't work again.
On this next slide, this goes over we draft bills and amendments. We write bill summaries for the committee. We provide background research on topics as requested, and we answer questions on bill content and legal consequences. And
Chair Schumacher, for House Fiscal, Mr. Berg and I will help the committee track revenue and budget effect of legislative and executive policy proposals. We will help you interpret and analyze revenue estimates and fiscal notes, and offer confidential fiscal analysis of spending, revenue, and policy proposals. I'll note one of these items Mr. Berg and I do is in your packets. It's called Budget Overview Brief. It is an attempt to distill down approximately 800 pages of the budget book to 30 or so, with three key elements. One is budget activity FTEs, all funds, base budget, and statutory references. So hopefully that is a tool for you all as you get up to speed here.
All right, and Mr. Chairman, we'll start with the general overview, some general information, including some of the when I say the entire Human Services budget, it is the accounts that are everything in this committee, everything in Chair Backer's committee, and also Human Services is looked at in the fund balance. And really, there's two things I would note off of this, that an all funds number that is $57 billion in total spending for the current biennium. And the thing that I would take off of this, as you see, is that DHS is the overwhelmingly large chunk of that at 96% in the current biennium. I'll note that 3.5% for the Department of Health, which makes it look small. That's still a sizable amount. I believe that Mr. Hardy said.
It would be approximately the 7th largest state agency if you took out the chart for DHS here. It's approximately $550 million general fund base budget.
Yeah, and then MNsure is a negligible amount, and although I should note that it doesn't include the internal service fund, people pay in, there is a reservation of funds that fund MNsure from the premium, the face value of the insurance. That's an internal service fund, so it doesn't show up in this chart. And the various boards include quite a number of health licensing boards, several other kinds of boards, but none of them are big enough to really register here. And you'll see a little bit how this flows into the budget soon.
Mr. Chair and members, healthcare and human services programs focus on healthcare, economic assistance, and social assistance programs. DHS is the primary executive branch agency that oversees human services programs. DHS supervises administration, ensures compliance with federal requirements, makes rules, and provides training, program evaluation, and technical assistance to counties. Counties typically do the day-to-day administration of programs, accepting applications, determining client eligibility, contracting with local service providers, and referring clients to services. The legislature may enact provisions that go beyond minimum federal requirements for the programs where there's an interaction there. And the policies that are set by the legislature are often influenced by federal requirements that are prerequisites to receiving the federal funding.
And members, this is, again, to sort of focus in on how we get to the current, the upcoming biennial budget. This is, again, for the current biennium that ends on June 30th of this year. It is the general fund only budget for the Department of Human Services by program or budget activity. This is the level we typically budget at. And so again, you'll see that the general fund only portion of DHS in the current biennium is $20.5 billion. There's a note there under that I'll just take a technical issue in how you look at this. There is a $146 million federal offset to that $20 billion number. It is not allocated to any single budget activity, but in the state general fund balance is taken as an offset to the total amount that's spent. So it appears at the bottom. You'll see that in a couple of slides when I get down to the actual budget activity level. Again, the thing to take out of this, I think, really is that the medical assistance program is by far the largest issue area in human services. I mean, it dwarfs everything else. Again, this is for the current biennium. I'm going to have some slides to transition because Members are probably aware that the legislature did a lot of reorganizing of the health and human services area, and I'm going to get to that next. A lot of what you see here, or some of what you see here, is now either has or is about to split off to a different agency. And I'll just note here the grant programs line, significant portions of that, but hardly all of it go off to direct care and treatment, or to Department of Children, Youth, and Families. Direct care and treatment will become its own agency on June 1st of this year. There are North Star Care for Children, MFIP, and MFIP Child Care are all going to the Department of Children, Youth, and Families, so those will come out. You'll see that in the next set of slides. This slide and the next four are meant to just show you where stuff was on the left in the current biennium at Department of Human Services and where it is either now or upcoming on the right. And I'm not going to go through all of this. It's a reference slide, but I'll note a couple of things. The second line down is the Children and Families Administration portion. That all went to Department of Children, Youth, and Families. Below that, I note that there are items that are related to homelessness and homelessness prevention that were in that part of the central office and remain at DHS. There'll be some technical work this year where we have to, I believe, create a new budget activity and reorganize this a little, but there are parts of it that stayed behind. You'll note on the third from the bottom line, the Office of the Inspector General is currently still at the Department of Human Services. That will separate into two pieces by the end of this June. The parts that are related to the remaining Department of Human Services will remain at that agency, and the parts of the OIG that relate to children and families programs will migrate to the Department of Children and Families, again, by June 30th of this year. Others you can see of budget activities that have simply moved to the Department of Children, Youth, and Families. I will note on this slide, there are a couple that say they had moved to DCYF with some exceptions. That again relates primarily to that homelessness and homelessness prevention items that remained with Department of Human Services rather than go to the Department of Children, Youth, and Families. That was a legislative decision on how to split those up. And then the final one here, the very last line, is direct care and treatment, which is a division of the Department of Human Services and which separates pretty much in its entirety into its own agency, again, on June 30th of this coming year. So when this committee appropriates money for direct care and treatment, it will be appropriating it to the new department, not for 26 and 27, not to DHS. But otherwise, it transfers pretty much en masse. That includes mental health and substance abuse, forensic services, and the sex offender program and like that. And you'll hear more about that upcoming. Getting a little more into budget information then for the upcoming biennium. This is the general fund base by programmatic level. And at this point, I'm looking at fiscal years 26 through 29, the upcoming biennium, 26 and 27, that we will appropriate money for in this legislative session. That's the sort of main chore of the legislature, is to appropriate a new budget. And this now is looking at general fund for only items that are left in. It doesn't include any of the things that are transferred out or any of that. This hopefully is closer to what will be this committee's area. Remains to be finalized, but that's what it should be. I'm not going to go over this slide in too much detail. I will say you look at programmatic areas for the Department of Human Services at the top. You can categorize that broadly into central office operations, which Mr. Harney covers, and sort of parts of it are Ms. Sunderman's. Forecasted programs, which are the largest chunk by far of this, and we'll see specifically what those are in the next slides. I'll take just a second now to mention for newer members, the way the budget works is that grant programs, the next one down, they typically remain the same. The base remains the same going forward. You have a grant of $1 million. It might be one time, but if it's an ongoing grant, then the grant base moves forward usually at the same level. Sometimes there are legislative directions that change that, but the forecast does not change grant programs. They are set by the legislature and they don't change in the forecast. However, the forecasted programs, as implied by the name, when the February forecast comes out, those are projected with usage and costs and quite a lot of factors and they change in every forecast. So this is data based on the November 24 forecast. All of those things in the forecasted programs line, we'll see in the next slide, will change in late February. I will note just that you see the way the state accounts for this portion of federal reimbursement, what we call FFP, is on the 5th line down. Federal reimbursement is just taken as a generic offset to the total cost of DHS and the fund balance to get to the net DHS appropriations level. You'll see the base for that is $17.5 billion for the upcoming biennium. And then you see direct care and treatment, which here is reflected as its own agency, which has a general fund base of around $1.1 billion. And there are a couple of smaller accounts here, the Minnesota Council on Disability and the Ombudsperson for Mental Health, DD, which are probably in this committee's interest. This takes that same data and takes it down to the next level, the level we typically budget at, which is the budget activity level. This is the way it's reported in the general fund balance, and this is the way we actually appropriate money at the legislature is at this level. Again, you'll see central office operations at the top. That's the base going into the session before the legislature does anything to it. One other technical thing I'll mention to members here is you hear a lot of people casually talking. The second set of columns, fiscal 28 and 29, are what we typically refer to as the tails or the out years. It is a little bit of a misapprehension or misimpression that people have that we are appropriating all the way across. We do not actually appropriate money in the tails. It's setting a base so that we know what current law going forward would cost if nothing changes. As I mentioned, forecasted programs always change, but so we don't actually appropriate the tails. So 26 and 27 are the base going into the legislature's business. Again, I'll just note the very last thing in central office operations is the Office of the Inspector General. That office, the base is here, but it will separate in June with part of it going to the Department of Children, Youth, and Families. So you don't have to worry about that here. And I guess one other thing I'll say is just a technical thing about how appropriations work. You'll see there is about the 6th line down, it says compulsive gambling, chemical mental health standing appropriation. I'll just mention there are a couple of main kinds of appropriations. What the finance committees are typically interested in are direct appropriations, which all these other things are. It's where the legislature, there's a number on the spreadsheet, the legislature shows up as an appropriation in a bill, which is listed. That's a direct appropriation. In the case of the compulsive gambling one I mentioned, it's the administrative cost. That is what's called a standing or a statutory appropriation, where the statutes actually set the appropriation and the legislature does not have to do anything to it unless they want to change it. There aren't too many, there are only 2 statutory appropriations in this, and they're both related to compulsive gambling, chemical mental health. At the bottom, the second group here is the large chunk of forecasted programs, and this is where a lot of the focus of this committee will end up being. It is programs that you have heard about, general assistance and housing supports and the behavioral health fund. The one I, again, will draw attention to here is medical assistance. That is a base of over $7 billion a year in the general fund. And this is the portions you'll notice in the note that are probably of interest to this committee: long-term care facilities, long-term care waivers, and elderly and disabled basic care. So this is about 75% of the medical assistance budget here. And then families and children basic care and adults without kids are over in, are going to be over in Chairman Backer's committee. I will just move on.
And Mr. Berg, with that 7 billion there, and that's the general fund spending, so there's the federal match on top of that that's being spent,
All right.
right?
This is a perfect place. I was trying to figure out where to work this in. But
You're welcome.
You've given me an opening there. The way Medicare or Medicaid rather works is it is a state-federal partnership. You heard earlier that the federal government sets the main law and the parameters, the state sets the state parameters, and then it's typically administered by the counties. But the funding of Medicaid is a state-federal partnership. At this point, what we refer to as FMAP, you'll hear that, Federal Medical Assistance percentage, the state of Minnesota gets currently 51.16% on most Medicaid expenditures. I will say sort of, you want to say routine Medicaid expenditures. The federal government pays 51.16%, we pay 48.84%. For the Children's Health Insurance Program, the CHIP program, the federal share is 65.18, and we have the residual. And then for the adults without children, the expansion population, excuse me, the federal government pays 90% of the cost for those people. The general FMAP percentage, every year the federal government issues a report that says the FMAP percentage for every state. Each state is individual. It's determined by a federal formula that is mostly based on personal income. The lowest percentage that you can have in federal law is 50%. Minnesota has been at 50% or just above 50% for the entire time I've done this. There are states which you can guess which ones, which have much higher FMAP percentages, and some as high as in the 70s. But because Minnesota is a relatively wealthy state, we pay half of the bill, approximately half of the bill.
Okay.
All right.
Thank you.
This chart is the grant programs that remain after the changing of the department jurisdiction. And there's only a couple of things here I will say, they are small compared to Medicaid or some of the other forecasted programs, but they still amount to $636 million over the upcoming biennium, the base does. And I just note a couple things. You'll see some right away that stand out on there are 3 grants that have children's in the name, and you might wonder why those are there. That is the residual part of those budget activities that I mentioned. The parts that were related directly to children have already transferred to Department of Children, Youth and Families and are not reflected in these numbers. The numbers that are left are the kind of residual stuff that we are likely going to reorganize into a new budget activity this year, but they're currently sitting the way they are. One other that I'll mention, you see the refugee grants line, refugee services, which is zeros all across. That budget activity has no general fund base and generally has never had a general fund appropriation except in fiscal 23 when some money was appropriated to it. Other than that, it doesn't have general fund money. This budget activity is federal refugee resettlement money, which goes to the Department of Human Services and then goes out to NGO partners, mainly Lutheran Social Services, Catholic Charities, and there's a third one anyway. They are the ones who actually deal with refugee resettlement. And Unless something is different, that will not have a general fund component. Then the last of these slides on the upcoming budget base, you see the new Department of Direct Care and Treatment and its budget activities, mental health and substance abuse, community-based services, forensic services, which is, if you're wondering what that means, it's what used to be called the State Security Hospital and the Forensic Nursing Home are the main parts of it. And then the MSOP is the Minnesota Sex Offender Program, and then DCT operations. Again, these are the budget activity levels at which we will appropriate funds. And then on the bottom is, again, the Council on Disability, which doesn't have any divisions. It's just one program. And the Ombudsman for Mental Health DD, which has two programs, though you'll note that there's a thing on U of M drug trial monitoring. Some years ago, there was a controversy over informed consent in some drug trials involving juveniles, and the legislature appropriated money specifically to the mental health ombudsman to monitor University of Minnesota drug trials for that, and that continues. Otherwise, it's the office as a whole. And the total you'll see at the bottom for all of these accounts is $8.5 billion in the general fund in '26, and almost $8.99 billion in '27. It is, are we the largest for 22nd? We're still the second largest general fund piece of the budget, I think, in '26, '27 after the general education formula. But in the November forecast.
Yeah, in the beginning, in the tails, the upcoming, after this biennium, Health and Human Services is due to take over K-12 as the largest budget area.
And that is sort of a change point between the budget part and general information and long-term care, Mr.
We'll open up for questions. Representative Murphy.
Thank you, Mr. Chair. I have a question about the refugee resettlements. You know,
Yeah.
you talked about Catholic Charities and Lutheran Social Services. Does that money cover flights too?
Mr. Mr.
Chair
Harney.
Schumacher, Representative, that's a good question. I know top line, the feds kick in approximately $127 million to the state for that program. I don't know the exact usage of that. I'll have to get back to you on that specific question, but that's a good question for sure.
Thank you. Thank you, Mr.
Representative
Chair.
Murphy. Any other questions before we move to the next section? All right.
Mr. Chair and members, the next portion of the presentation is on long-term care. Long-term care services and supports are available to the elderly and disabled through sort of three different mechanisms. There are programs that are offered under medical assistance, which, as Doug mentioned, is a federal-state partnership. There are some state-only funded programs, and then there are also some programs that are administered through the Board on Aging with some state general fund money and also some federal Older Adults Act funding. This slide is a table that shows the long-term care services provided under MA. It shows monthly average recipients and then federal and state funding for fiscal year 2024. For the MA programs, persons eligible under elderly or disabled categories must meet income and asset standards that are lower than the standards for other eligibility categories within MA, in addition to other eligibility requirements. To be eligible as elderly, a person must be age 65 or older, and to be eligible as a person with disabilities, the person must satisfy the disability criteria that's used by the Federal Social Security Administration or the State Medical Review Team. I'll just note that nursing facilities and intermediate care facilities for persons with developmental disabilities are facilities, and the remainder of these services are all home and community-based services. A couple of things to note, the personal care assistance program is currently being phased out and is being replaced by a new program called Community First Services and Supports. That phase out began on October 1st, is my understanding, and will continue through September 30th of this year. The other thing to note is the home and community-based waivers. There are 5 of those. Each one serves a slightly different group of people. There's a community alternative care, the CAC waiver, which provides services for people with chronic illnesses who meet the level of care that's provided in a hospital. There's the CADI, the Community Access for Disability Inclusion waiver, which provides services for people with disabilities who need the level of care provided in a nursing home. There's the Developmental Disabilities, the DD waiver, which provides services for people who need the level of care provided in an intermediate care facility. The brain injury waiver provides services to people with a traumatic or acquired brain injury who need the level of care that's provided either in a nursing home or a neurobehavioral hospital. And then the elderly waiver, which provides services for the elderly who are at risk of nursing home placement. These waiver services cover 2 different types of service. They cover services that are necessary to avoid institutionalization that are not covered under the regular MA state plan services. And they also cover services that are extensions of Minnesota's MA state plan services. The Department of Human Services must apply to the Federal Centers for Medicare and Medicaid Services in order to have these waivers, and then they need to be renewed every so often. The other thing to note is that the Department of Human Services for the past several years has been in the process of a program that they call Waiver Reimagine, which is going to consolidate the 4 disability waivers down into 2. And I believe that transition is supposed to start on January 1st of next year. This slide shows MA enrollees and expenditures for fiscal year 2023 by category, and basically it's just here to show that people with disabilities or blindness and seniors make up a very small percentage of the enrollees. They make up about 15% of enrollees, but they make up about 60% of the spending in MA. This slide shows long-term care programs that are state-funded programs. The long-term care consultation services provide screening, assessment, and information and education services to help individuals access and decide on the appropriate level of long-term care services. Family support grants provide state cash assistance for maintaining a child with developmental disabilities or a related condition in the family home, and the funds are used for those expenses that are incurred as a result of the disability. The Consumer Support Grant Program is a state-funded alternative to MA reimbursed home care. It's not available in every county, and this program is also currently being phased out and replaced by the CFSS program. And then the SILS program is a program that's provided to adults with developmental disabilities or a related condition in their home and community to maintain or increase their ability to live in the community. And this is a joint state and county funded program. And then finally, essential community supports were created back in 2014, 2015, around that time period, to provide services to people who are no longer eligible for nursing facility services or certain waiver services due to changes that were made back at that time to the nursing facility level of care. And then finally, we've got the programs that are administered by the Board on Aging. which is a 25-member board whose members are appointed by the governor. It is staffed by the Department of Human Services, and it's housed within that agency. And one of the primary functions of this board is to administer the federal Older Americans Act funding. And you can see here the various programs and services that are administered through the board. I'll just touch on a couple of them. The Senior Linkage Line is a free telephone service that provides elderly persons with information on and assistance in accessing a range of community services, including things like housing, home care, chore help, caregiver support, and meal delivery. And then I'll also touch on the Office of the Ombudsman for Long-Term Care. This office serves as an advocate for and investigates and resolves complaints concerning the health, safety, welfare, and rights for people receiving long-term care services. This office is primarily state-funded, but it also does receive some of the federal Older American Act funding as well. And unless you have any questions for me, I will turn it over to Ms. Sunderman.
Looks like we might have a couple. Representative Gilman.
Thank you so much, Chair. My question is, the SILS program, do you have information then based on, biennium to biennium, the growth in the program? How many more folks are on the program, or does the dollar amount go up based on the need? That was one question I had.
Okay. Who would like, Ms. Punelli?
Mr. Chair, I don't have current enrollment numbers at my fingertips. I can certainly look into that and get back to you. I don't know if Mr. Berg has any information about the funding.
I have basically the same answer. I don't have it off the top of my head, but we can look into it and get back to you.
That'd be wonderful.
Gilman.
Thank you so much, Chair. And then last thing that I have, Chair, is just wondering also about the caregiver grants as well. That would be just something I'd be curious to see the growth in that as well. Just to get that data would be great. Thank you.
All right, any other questions for Ms. Punelli? All right, thank you.
Mr. Chair, members, I will begin talking about behavioral health. And just behavioral health consists of both substance use disorder treatment and mental health treatment generally. But we'll start with substance use disorder treatment, commonly referred to as SUD treatment. You'll hear that all the time in this committee. The three main components of SUD treatment are assessment, which typically consists of an interview to evaluate a person's substance use and SUD treatment needs and placement. Before, I believe, 2022, this was done through the counties, but starting in 2022, it changed to direct access. So an individual can go directly to a provider, and actually must go directly to a provider to access SUD assessment services. And the next big bucket is treatment. This can consist of, depending on the individual's needs, detoxification or withdrawal management, residential and non-residential treatment options, sober homes, and extended care. And then the last bucket of services is recovery services, which generally consists of services from recovery community organizations, peer-based recovery support services, and ongoing service coordination. And generally, in Minnesota statutes, SUD treatment providers are licensed by DHS under the requirements of Chapters 245A and 245G. Counties and tribes are responsible for determining financial eligibility for publicly funded SUD treatment. and coordinating placement and treatment services for clients enrolled in managed care organizations, and for paying the state 22.95% of the cost of services for individuals who are not enrolled in MA. These services are generally provided via the Behavioral Health Fund, which I'll get into on the next slide. So as I said, publicly funded SUD treatment services provided by managed care, which is typically MA, Minnesota Care, or a prepaid medical plan, or through the Behavioral Health Fund. In order to get funding for treatment through the Behavioral Health Fund, recipients must be either enrolled in a public health care program, or they must meet Behavioral Health Fund income and household guidelines and have insufficient insurance coverage for the services. And for all of, to receive any publicly funded SUD treatment services, an individual must meet clinical requirements. Moving on to mental health services. As with many things in human services, Minnesota's publicly funded mental health services are supervised by DHS and administered by the counties. Counties are responsible for developing and coordinating publicly provided mental health services for children and adults. Counties may provide services directly or contract with private entities to provide services, and they may also refer individuals to community resources. Funding comes from federal, state, and county sources, including medical assistance and children's mental health grants and adult mental health grants, and public health care programs and private insurance pay for some mental health services as well. The programs and services must comply with various statutes, the Children's Mental Health Act, the Adult Mental Health Act, Minnesota Statutes Chapter 245I, which is the Uniform Service Standards for Mental Health Providers, and other statutory standards within medical assistance for specific types of programs. These are the general components of mental health service delivery. We start with assessment. This includes a diagnostic assessment, which determines eligibility for all of these publicly funded mental health services. And there are also functional assessments, level of care assessments, and crisis assessments, depending on the type of service needed. Then providers must develop an individual treatment plan and engage in community support planning. Then there's actual delivery of mental health services, and then there's reassessment and continued evaluation. Moving to the different types of mental health services available, we'll start with crisis and emergency mental health services. First, there's a 24/7 suicide and crisis lifeline number, which is just 988. Each county and tribe has a designated mental health crisis response services phone number, which can be found on DHS's website. And 988 also connects people to these local crisis response services. In addition, 911 emergency services must also include referrals to mental health crisis teams. Then we have mobile crisis response and intervention, which are teams that go out to people in mental health crises. Then we have community-based crisis stabilization services, and finally, residential crisis response and stabilization services, which are more short-term residential services for individuals in crisis to restore the level of functioning and avoid the need for more intensive long-term services or hospitalization. Moving to residential mental health services, these include short-term inpatient hospital psychiatric treatment, intensive residential treatment services, commonly referred to as IRTs. These are medically monitored services for adults with mental illness, and they're non-hospital but residential facilities, and they're relatively small. I believe it's 5 to 16 beds. And then there are direct care and treatment facilities. Most people will be familiar with the Anoka Metro Residential Treatment Center, and then there are also forensic mental health services which were previously called the Minnesota Security Hospital. And people receiving those services are typically under a civil commitment. Moving to, these are community-based, otherwise known as non-residential or outpatient adult mental health services. There's quite a list, but starting with assertive community treatment, then adult rehabilitative mental health services, mental health targeted case management, partial hospitalization, adult day treatment, intensive outpatient treatment, which includes dialectical behavioral therapy, certified community behavioral health clinics, commonly known as CCBHCs. They may provide many of these community-based services in sort of one setting. And then similarly, behavioral health home services, that's a service set that integrates primary care with mental health services and some social services and care coordination. And each of these services has pretty specific eligibility criteria, and more information can be found on the DHS website, and also there's a House Research publication that goes into some more detail on these services. This is, I think, a pretty good visual from the DHS website that shows the different types of adult mental health services with sort of increasing intensity, as you can see. And like I said, you can get more information on their website or House Research publications. This is the same chart, but for children's mental health services. Going to the next one. In general, the children's mental health services continuum largely mirrors the adult continuum, but includes this rather long list of in additional specialized programs that are just for children and adolescents. There's a lot of detail in statutes on the DHS website and in our publication. But the ones you'll probably hear the most about are PRTFs, which are psychiatric residential treatment facilities. Those are just for children. And probably also children's therapeutic services and supports. That's a large bucket of services under MA. Moving now to direct care and treatment. These are state-operated healthcare services for individuals with complex needs related to mental illness, substance use disorder, developmental disabilities, traumatic brain injury, and individuals committed as mentally ill and dangerous. As Mr. Berg mentioned, this is currently a division of DHS, but the legislature enacted legislation in 2023 to move DCT to a separate agency effective July 1, 2025. So soon it will be its own separate agency. It'll be governed by an executive board and a CEO, but the functions will remain the same. This is a map that is rather hard to see, but is available on the DHS website. And this just shows where the direct care and treatment sites are statewide. This slide covers in not a great deal of detail. There's a lot of detail on the DHS website, but these are the services provided by direct care and treatment. There are adult mental health services, child and adolescent behavioral health services, community addiction recovery enterprise services, otherwise known as CARE, community support services, which includes rehabilitation and vocational services. And then there are rehabilitation services, and then forensic services is a fairly large bucket of services that includes the Minnesota Sex Offender Program, Forensic Mental Health Program, Forensic Nursing Home, Transition Services, and the Competency Restoration Program. And then finally, there are special care dental clinics to provide dental care to patients with complex needs. They can't be served in private dental facilities. And this slide discusses the Minnesota Sex Offender Program. This is a court-ordered treatment program for individuals who are civilly committed by the court as sexually dangerous persons or as having a sexual psychopathic personality. Typically, an individual begins treatment at Moose Lake and transfers to the St. Peter facility if they progress in the treatment process. And St. Peter has both a secure perimeter and a community preparation services area. As of November 18th, 2024, there were 739 individuals receiving treatment in MSOP facilities. And then individuals can be discharged or provisionally discharged by the Special Review Board and the Supreme Court Appeal Panel. All right. If there are any questions, I'm happy to answer them. Otherwise, I'll go on to vulnerable adult protections.
Looks like we may have a couple questions. Representative Murphy.
Thank you, Mr. Chair. I have a question about the assessments. Who can do those? Social workers, are they able to do them? Do they have to have a second opinion or a doctor to help? What is the current law?
Mr. Chair, members, assessments for substance use disorder services or
We're
mental
just
health,
looking at page
mental health
28,
services?
your slide, it just talks about assessments. That's, I guess I was just wondering, components of healthcare service delivery, and it says assessment, and I was just kind of curious, who's able to do it? And I had a situation where a social worker actually, took a young child and was able to put them in in special services, and there was a lot of questions around it, so I'm just wondering who can do it.
Ms. Sunderman.
Mr. Chair, members, assessments for mental health services, the requirements for who can administer an assessment are found in Chapter 245I in statute. I believe it is typically mental health professionals or clinical trainees, which is further defined, and off the top of my head, I cannot list them, but I can get you that information, the specific information as to the providers.
Representative Murphy.
Thank you, Mr. Chair.
Representative Knudsen.
Thank you, Mr. Chair. I also have some questions about assessments, but just in the chemical dependency part, substance use disorder part, did you say that now, instead of like doing a Rule 25 by the county, now they're doing it by the provider?
Ms. Sunderman.
Mr. Chair, members, yes, the Rule 25 changed to direct access about 2 years ago.
Okay,
Representative
thank you.
Knudsen.
And just a follow-up. That's interesting to me. So if that's being done that way, the provider is providing the assessment, how is that financial part? How are they being assessed for the financial need then? Are they doing another assessment with the county, or where is that overlap, I guess?
Ms. Sunderman.
Thank you.
Mr. Chair, members, the assessment is on the clinical side of things. I believe in order to get behavioral health funding, the county would do a separate
So two.
application or eligibility process.
Okay, thank you.
Representative Knudsen. Representative Gander.
Thanks, Mr. Chair. So I'm an optometrist, and each year we do training for our team on fraud, waste, and abuse, because it's a big deal. It's an ethical thing, but it's also a fiscal thing. Every time there's a fraudulent activity or wasteful activity or an abuse activity, somebody pays. And largely what's going to happen is the folks who should receive the benefit won't, because it's been squandered, and the people who pay for it will pay too much because it's been wasted. Now we're gonna find those instances, and we're gonna prosecute those. We're in the middle of that. There are some huge dollars right now being worked on, but can we get ahead of it? Can we use AI or other metrics to look for the outliers of who are squandering the money that just clearly nobody could have administered that amount of care or that number of meals in that period of time in that jurisdiction? Can we get ahead of it using AI or other metrics to try to stop this before it happens?
Representative Gander, that's a great question for the rest of the legislature and the department. House Research really doesn't have that. They may have their own ideas, though, if they want to share, but we'll save that question, and that's really something that we should be answering, and I think you're on the right track with that.
I sure hope the agencies are on board, though, because ultimately that's where the rubber hits the road. Thank you.
Thank you, Representative Gander. Any other questions? All right, proceed. Thank you.
All right, Mr. Chair, members, moving to services for vulnerable adults. Vulnerable adults are individuals who are age 18 or older, who are impaired physically, mentally, or emotionally, or unable to protect themselves from maltreatment, residents or inpatients of a facility, individuals who receive certain outpatient services listed in statute, and individuals who receive certain home care services listed in statute. Slide covers maltreatment reporting related to vulnerable adult maltreatment. Maltreatment means abuse, neglect, or financial exploitation, and these are further defined terms in statute in section 626.557(2). Certain people called mandated reporters are required to report suspected maltreatment, but any person may voluntarily report suspected maltreatment of a vulnerable adult. Reports of suspected vulnerable adult maltreatment must be made to the Common Entry Point, which is the Minnesota Adult Abuse Reporting Center, otherwise known as MARC, which must be available 24 hours a day to accept reports. After a report is made, the report is screened and referred to the appropriate lead investigative agency within 2 working days. And then counties, law enforcement, DHS, and MDH assess and investigate allegations of maltreatment within statutory timelines depending on where the alleged maltreatment has occurred. And then counties directly provide protective services when needed. And we have a publication on the House Research website specifically on the Minnesota Vulnerable Adults Act if you'd like much more detailed information on that act.
Mr. Chair, unless anybody has questions about vulnerable adult protections, we'll move on to housing and community supports.
Looks like you're good.
The housing and community support programs provide assistance to low-income households, and each program provides assistance to a slightly different population. The General Assistance Program is a state program that provides cash assistance to low-income single adults and childless couples who fall into specified categories and meet the eligibility requirements, including income and asset requirements. And eligibility is primarily defined in terms of disability and unemployability. The Supplemental Security Income Program provides cash assistance to aged, blind, and persons with disabilities. In order to qualify, an individual must be age 65 or older, blind, or have a disability according to criteria that's established by the Social Security Administration. And an individual must also meet program income and asset limits and satisfy other additional eligibility criteria that are all in federal law. The Minnesota Supplemental Aid Program is a state program that provides supplemental cash assistance to needy, aged, and blind persons or persons with disabilities who are SSI recipients or would qualify for SSI except for excess income. And this is a federally mandated state supplement to the SSI program. And then finally, the Housing Support Services Program provides payments on behalf of eligible persons to pay for room and board and related housing services. And in order to be eligible for these payments, an individual must have county approval for residence in a housing support setting and must be either aged, blind, or a person over 18 years of age and disabled and meet specified income and asset standards, belong to a category of individuals potentially eligible for GA and meet specified income and asset standards, and also lack a fixed adequate nighttime residence upon discharge from a residential behavioral health treatment program or meet specified other disability criteria, and lack a fixed adequate nighttime residence upon discharge from a correctional facility. The vast majority of these settings are adult foster care homes, And I believe the current basic room and board rate is $1,170 per month for a group setting or $1,220 per month for a community setting.
And Ms. Punelli, how are those rates set? Is that just right in statute, or how are those room rates?
Mr. Chair, I believe there's a formula in statute that sets that, and it's adjusted each year.
Okay, thank you.
On the next slide, this is just going over the administration of these programs. The General Assistance, Minnesota Supplemental Aid, and Housing Support Programs are state supervised, county administered programs. This is an instance where the county agencies do the day-to-day administration of accepting applications and making eligibility determinations and so on. The SSI program is a federal program that's administered through local offices of the Social Security Administration using uniform nationwide standards. This next slide shows the income eligibility standards for these various programs. In general, the income limit for the federal SSI program is the federal benefit rate, which in 2014 was, I believe, $943 per month for an individual or $1,415 per month for a couple. To receive GA, an individual's net income must be less than $350 each month. And then for MSA, there's a standard that's set in statute. And I already mentioned what the housing support standard was. The asset eligibility standards for general assistance and housing support, the equity value of personal property must not exceed $10,000 for both applicants and participants. And personal property is limited to cash, bank accounts, liquid stocks and bonds that can be readily accessed without a financial penalty, non-excluded vehicles, and the full value of business accounts that are used to pay expenses that are not related to the business. The federal SSI asset limit is $2,000 for an individual and $3,000 for a couple, and the MSA asset limit depends on if a person is a recipient of SSI as well or not. If a person is also receiving SSI, then they have to meet the SSI asset limit, and if not, then they meet the general assistance asset limit. This slide just shows the maximum monthly benefits for these programs for 2025. And this next slide shows the fiscal year 2024 number of recipients and expenditures and where the expenditures came from for each of these programs, whether it was state, federal, or local funding. And I'll just mention that there's a lot more information about all of those programs on the House Research website. I've got a publication on each of them, so if anyone is interested, there's a lot more information. So this last slide that I'm going to go through is programs for persons experiencing homelessness. As you can see, there are a handful of different programs that are administered by the Department of Human Services for people experiencing homelessness. The first one, the emergency services grants are awarded on a competitive basis and provide emergency shelter, motel vouchers, day shelter, and essential services to children, unaccompanied youth, single adults, and families who are experiencing homelessness. The transitional housing grants are provided to eligible recipients to initiate, maintain, or expand programs to provide transitional housing and support services for persons in need of transitional housing. This funding is typically limited to 36 months, I believe. The Homeless Youth Act provides competitive grants for street and community outreach and drop-in programs, emergency shelter programs, and integrated supportive housing and transitional living programs to reduce the incidence of homelessness among youth. And last, the long-term homeless supportive services are for people who have lacked a permanent place to live continuously for 1 year or at least 4 times in the past 3 years. And unless there are any questions about any of those programs, I'll turn it back to Ms. Sunderman to go over program integrity and operations.
I see a question here from Representative Gordon.
Thank you, Mr. Chair. I just was curious on the limits for the assistance programs. I mean, are those stackable? So, I mean, if you have one program that someone is eligible for, and does that put them over the limits for, say, for a different one, you know, or do those assistance programs not count against their income, I guess, is?
Ms. Pinelli?
Right.
Ms. Pinelli.
Mr. Chair and members, for the general assistance SSI and MSA, a person could be receiving both SSI and MSA at the same time. You wouldn't be receiving general assistance if you were eligible for SSI. And then with housing support, I believe you could be receiving one of these other programs and also receive housing support as well if you met the income and asset limits and other eligibility requirements.
Okay, Representative Gordon.
Thank you, Mr. Chair. So if they're receiving one of those benefits don't go against the income requirements, basically. So they don't count as income, I guess, is what I'm asking.
Ms. Pinelli?
Mr. Chair, I would have to go back and double check on what counts and what's excluded from income for these various programs.
Representative Gordon.
That's all I had. Thank you.
All right, any other questions? Okay, thank you.
All right, Mr. Chair and members, this is our last big section of the presentation on DHS program integrity and operations. The DHS Office of Inspector General, commonly referred to as OIG, is the regulatory authority that oversees DHS licensing activities, background studies, and program integrity services. And there are 3 divisions within OIG: the licensing division, the background studies division, and the financial fraud and investigations division. Starting with DHS licensing, DHS issues licenses or certifications for approximately 20,000 programs and providers at any given time. Sometimes it's a little more, sometimes a little less. DHS directly licenses or certifies currently child care centers, children's residential facilities, mental health treatment programs, SUD treatment and detox programs, home and community-based services, child placing agencies, and some of the direct care and treatment programs. The child care and foster care licensing functions within DHS, and you'll see that are currently delegated to the counties and will continue to be, the oversight of those will be transferring to the Department of Children, Youth, and Families as of July 1. They have not transferred yet. Certain licensing functions, like I mentioned, are delegated to counties, mainly family child care and foster care licensing, family foster care licensing. Some private agencies are authorized to perform licensing functions related to child placement and child foster care. But DHS directly licenses and monitors all other programs and issues correction orders or other licensing sanctions for violations. DHS investigates alleged licensing violations and issues licensing actions, like I mentioned. This is under all of these sanctions are under Chapter 245A in statute. DHS also receives and investigates allegations of maltreatment of children or vulnerable adults served by DHS licensed programs or providers. The vast majority of the reports DHS receives, maltreatment reports, are for vulnerable adult maltreatment. This is partly because most child maltreatment reports are not reported to DHS because they don't occur in licensed programs. And these reports are instead reported to counties and handled by counties. DHS does also investigate allegations of maltreatment in juvenile correctional facilities that are licensed by the Department of Corrections. And then, just for an idea, some numbers, the most recent ones I could find are between December 2021 and November 2022. DHS received 7,730 maltreatment reports. 8% of those reports were assigned for investigation. Maltreatment was substantiated, and 33% of those that were received, assigned, and completed. And for more details on this, DHS has a maltreatment report and investigation dashboard on their website, which gives a lot more detail on the actual numbers of maltreatment reports they receive. Moving to DHS provider fraud prevention. The DHS OIG oversees fraud prevention and recovery efforts for DHS administered public programs. There are various procedures that the agency has and initiatives to reduce provider fraud and improper payments. This includes MA provider investigations, provider screening, and audits to identify and recover overpayments and identify underpayments. Minnesota Care audits and investigations, and then there are also child care grant audits, CCAP, Child Care Assistance Program, provider investigations, and providing technical assistance. It also includes efforts to educate providers, recommend system edits to prevent improper claim payment. Again, conducting provider screening visits, and then operating a surveillance and integrity review section, otherwise known as SIRS, to investigate MA provider and recipient fraud. And for some of these activities, DHS contracts with outside entities to conduct post-payment audits, provider audits. DHS OIG also engages in efforts to reduce recipient fraud or prevent recipient fraud. They conduct public program recipient fraud investigations and other fraud prevention programs to prevent and reduce improper payments and resolve eligibility questions for caseworkers. As part of this, there are fraud prevention investigation FPI grants to counties for investigative activities. There's also the Minnesota Restricted Recipient Program, where certain MA recipients are placed in a case management program, essentially, after reviews that show abuse or misuse of medical services. Under this program, the recipients are restricted to one primary care provider, clinic, hospital, and pharmacy for 24 or 36 months to reduce costs. And the latest information I could find was that the restricted recipient program typically reduces costs by $5,000 to $6,000 per year per recipient. Moving to DHS background studies. DHS conducts background studies on all individuals who provide direct contact services to children or vulnerable adults in DHS licensed programs. Direct contact means providing face-to-face care, training, supervision, counseling, consultation, or medication assistance to clients in these programs. DHS also conducts background studies for programs licensed by MDH, the Health Department, and the Department of Corrections. And the background studies can also be required for others that don't work directly in these licensed programs, such as guardians and conservators, foster care providers, individuals seeking to adopt a child, and individuals over the age of 13 who live in the household where a licensed program is located. The DHS background study system is called NetStudy 2.0. It requires fingerprints and photographs for each individual being studied. It searches a wide range of records, including Bureau of Criminal Apprehension records, Minnesota Court Information System records, National Crime Information Database, FBI records under certain circumstances, not for all providers, records of substantiated maltreatment, professional licensing records, and predatory offender registries. It also electronically updates study subjects' criminal records and provides electronic employer notifications of those updates. The very long lists of disqualifying crimes and conduct are listed in Minnesota Statutes 245C.15, and there are different levels of, or different times of disqualification. So there are permanent disqualifications, 10-year disqualification, or 15-year disqualifications, 10-year and 7-year. And there's a separate subset of disqualifications for family foster care providers as well. It's a very long section, but worth a read. And in calendar year 2023, DHS received 507,517 background study application requests, to give you a general idea of the volume the agency handles. And that concludes our presentation. We've listed on here the website for House Research publications in the Health and Human Services subject areas. We also listed the Fiscal Analysis Department website and the DHS website on here. And here we have our individual contact information if you would like to reach out.
All right, thank you for all the information that you've given us today. And I think that was an appropriate level of just where, at least for me, where I'm at with this, for the understanding piece of that. So really do thank you a lot for your work on that. Are there any questions for the team here? Representative Murphy.
Thank you, Mr. Chair. Just regarding fraud, you know, it seems to take a while before we catch stuff. Are there legal hurdles or sometimes that are involved in, you know, just the process of, you know, coming to terms with the fraud? It just seems like it takes a while.
And Representative Murphy, I'm not sure if that's the best question, but it looks like they may have an answer.
Oh.
Not the best question, I'm sorry. The best question for them. Ms. Sunderman.
Mr. Chair, members, I can't speak directly to the OIG's processes, but I can tell you that oftentimes investigations are occurring and the general public doesn't know about it because active investigation data is classified under Chapter 13 as private data. So I think speaking to the OIG about this directly would be the most helpful about their individual processes and why it might seem to take longer than would be ideal.
Representative Murphy.
Sounds good, thank you.
All right, Representative Jacob.
Thank you. So throughout the presentation, I wrote down different times, and I come from a county government background. I heard the words county administered, locally funded, delegated to counties, handled by counties, and just kind of a overarching question. When you delegate these responsibilities down to counties, how do you determine when you say locally funded? How do you determine what percentage the state is going to pay for the services that it provides to the citizens of Minnesota versus how much you're going to put off on local property taxes? Where is that determination made and how?
Mr. Berg.
Mr. Chair, Representative, I guess I would say that it varies greatly by what you're talking about. There are county administered programs where there are grants that go out to the counties, and so that's state money going out to the counties for a purpose. There are programs where there is statutory determination of the share that's paid. That happens in several cases, like when there are people put under court order to go in, the county, once they're no longer, to get into something we haven't brought up here, the 48-hour rule, if a individual is in a county lockup and then the judge signs a commitment order, State law requires them to be moved to DHS custody. That doesn't always happen on the timeline that the law anticipates. The state statute puts a share of the cost on the county from differing parts of where they are in the system. There are a few of those that's currently under a special situation as they try to resolve the 48-hour rule problems. But there are a variety of different situations there, I guess is what I would say.
Okay, Representative Jacob.
It's just something I'll pay close attention to moving forward. Minnesota is one of 10 states, 40 states. The state just implements these programs on their own, and 10 states, the state delegates it down to the county implements it, and it becomes highly inefficient. So.
Thank you, Representative Jacob. Any other questions? Representative Knudsen.
Hi, thank you. Thank you, Chair. I just have a question, just the last stat that you gave us with over 500,000 background requests how long is that turnaround? Do you have any idea?
Mrs. Sunderman.
Mr. Chair, members, off the top of my head, don't recall what the turnaround time is. I believe it's fairly quick under the new system. I want to say within a week, but don't quote me on that. I don't know that I have the statistics on like how quickly the turnaround is. That would have to come directly from the department, but it is fairly quick under the new system.
Representative Knudsen.
Thank you.
Any other questions? All right, seeing none, thank you again to House Research, House Fiscal for your work today and helping us start to get into everything that we have here. Programming note, because the session's been so easygoing so far, the plan as of right now is to continue with informational hearings next week and the following week. We'll start to get into some of these areas that we talked about in the forecasted piece and hear from providers on those so we get an idea of what we do for them and what they do for us from their perspective. And that's how we'll be doing more of the informational hearings coming up, including Representative Jacob's counties in there. We want to hear from them on how they see their role and how they see all of that. So with nothing else before the committee, we stand adjourned.